Healthcare edition of Kansas City Week in Review is made possible by the generous financial support of the Healthcare Foundation of Greater Kansas City, working to make Kansas City a healthier place by helping the uninsured and underserved get the care, support, and education they need. Additional support has been provided by
The Reach Healthcare Foundation is a regional health organization committed to improving access to quality, affordable health care for underserved individuals in the Kansas City area and surrounding region. More info available at reachhealth.org.
You have said America should hold you accountable, which is why today, Madam Secretary, I repeat my request for you to resign.
This is a huge opportunity for millions of Americans, millions of people here in the Kansas City area who don't have affordable coverage.
This week we're joined by the woman once charged with leading the nation's healthcare system, former Health Secretary and Kansas Governor Kathleen Sebelius. Plus, we bring you a broad ideological swath of experts as we separate the fact from the fiction on Obamacare to Medicaid expansion.
I was called by the New Republic Obamacare's single most relentless antagonist.
It's created a financial pressure on the hospitals that I think has been significant. We still see the same number of people or more coming through our doors.
A dozen states actually had a reduction in poverty, and a majority of those states did not expand Medicaid.
We're on location at UMKC for this hour-long healthcare status report as we partner with the American Public Square Civility Project. We'll join moderator former Ambassador Alan Katz in just a moment, but first a backgrounder on the pesky, divisive issue of Medicaid expansion.
I do not think that this Missouri legislature would pass a straight Medicaid expansion. They've been pretty clear about that.
Now, Kansas originally said no to the federal government. Why did you make that decision?
Well, Obamacare is not working and it's not going to work.
From our partner in the Heartland Health Monitor, here's reporter Jim McLean with the KHI News Service.
A big part of the seemingly endless battle over Obamacare is about Medicaid, whether to expand the health care program for the very poor to cover adults who are a little less poor. It's another one of those red state, blue state battles. 31 states have expanded their Medicaid programs, but political leaders in 19 states, including Kansas and Missouri, have so far said no to expansion. That has effectively denied coverage to about 80,000 Kansans and nearly 300,000 Missourians, and it has cost both states billions of federal dollars. Dollars that hospital administrators like Truman Medical Center's Charles Shields say are urgently needed to offset cuts in other federal programs and reduce the number of patients that must be treated regardless of whether they can pay their bills.
For the 41,000 patients who are uninsured that we care for, we estimate that at least 3/4 of them would be covered if Missouri were to expand Medicaid. That would have a dramatic impact on that $139 million of uncompensated care, would probably reduce that significantly, over $100 million worth.
About 170 miles south of Kansas City, hospitals in Independence and Coffeyville, Kansas are facing the same pressures. The financial challenges have forced the longtime competitors to merge.
Quite frankly, the easier decision for us would have been to let the hospital in Independence close and just let the business go where it's going to go, and we're going to have a presence there. We think the more appropriate decision was to be a partner with them in how healthcare is delivered and create a new model.
Okay. It's kind of like you're home away from home anymore, huh?
It is.
Yeah, how's it been going?
Good days, bad days, you know.
But of course, it's people who are most affected, people who desperately need health care but can't afford it. Monty Campbell's Parkinson's disease cost him his job at a local refinery. His tremors got so bad he couldn't hold on to tools or even a phone.
I just want to check kind of what your symptoms are doing. Go ahead and put your hands on mine.
He's applied for disability, but in the meantime, he's got no coverage to help cover the cost of the medicines he needs. Monty believes elected officials in Topeka are putting politics above the needs of people like him.
You know, I've paid taxes all my life, and I've paid into the government. I've supported politicians. And now I just feel like I'm thrown out to the curb. Got to quit thinking dollars and cents and start thinking of human life.
Dr. Julie Griffin runs the Coffeyville Clinic where people like Monty can get some basic health care services, even if they're uninsured.
All right. Can I see Mommy for a bit?
I think what you said is that you just want to get Governor Brownback and maybe some legislators here. I mean,
Right.
Why would that make a difference?
Right. Because I do believe that part of why they became elected officials is because they wanted to make a change and they wanted to do it in a personal way. And so I just want them to return to kind of their grassroots efforts and just hear the stories of the people that elected them, just like Monty talked about.
And you think that would make a difference? It would take it out of the political realm and just make it more.
I think it's a
Bring it
different.
home for
I think it's a different environment. I think when you have that conversation on a one-on-one level, then the sound bites and the jargon and the ideology that takes a backseat, and that's what we need in Kansas right now.
Susan Walter needs a heart transplant. Complications with the birth of her almost 2-year-old son, Nicholas, damaged her heart. But no heart surgeon will see her until she has either Medicaid or private insurance. So she waits and worries.
It's stressful every day, not knowing if I'm gonna have to leave my kids behind, or it's just stressful.
You were secretary during the creation of and the passage of the Affordable Care Act. Part of that, of course, was the issue of Medicaid expansion. How significant was it in the original thought process in creating this? And how significant was the Supreme Court decision, which has sort of made it different in different parts of the country?
The expansion of Medicaid was a sort of fundamental part of looking at a continuum of care. It was seen as a way to reduce the 40 million uninsured folks we had in this country, but also to begin to shift toward preventive care and health care as opposed to acute care. So that's the way the law was written. It was anticipated that all states would take advantage of what is, I think, the single most generous federal state revenue sharing program. 100% of the costs of the uninsured for the first 3 years, and then gradually reducing the federal share, but never less than 90% over a 10-year period of time. And what we have now post-Supreme Court is a real patchwork where 29 states, Republican and Democratic governors, have chosen expansion. And I think there are 3 more in the pipeline with Utah and South Dakota and others looking at expansion. And then the rest of the states still debating whether or not they will insure those individuals. In Kansas, right now, if you are a parent in a family of 3 and make less than $5,600 a year, $5,600 a year, you qualify for some health care. If you do not have children, or if you're a parent making more than that, you qualify for no assistance. And I would say in Kansas, again, a lot of the people who are uninsured are students and veterans and very low-income workers, but there's a real gap.
Let's expand the conversation a little. We have with us tonight the Cato Institute's Director of Health Policy Studies. He's the co-editor of Replacing Obamacare and co-author of Healthy Competition. Please join me in welcoming Michael Cannon. Let's focus for a minute, if we can, on Medicaid. And the concept of Medicaid expansion that was an integral part of this. Do you feel with the Supreme Court decision that it's made things worse or better?
It's a complicated question because I want to say that what the Supreme Court did there, as it has done elsewhere, was actually to rewrite the law in a way that Congress never intended. And so while I am glad that states have more control over the implementation of this law and that they're not being coerced, I am also troubled by the fact that the Supreme Court essentially changed the law into a law that could not have passed Congress. You'll see in your program that I was called by the New Republic Obamacare's single most relentless antagonist. And they didn't mean that as a compliment. The first thing that would happen if either Kansas or Missouri expanded Medicaid is what? A whole lot of people between 100% and 138% of the federal poverty level will lose their health plans. They're enrolled in the exchanges now. If Kansas or Missouri expands, they're thrown out of their exchange plans, like so many Americans were by this law, and then they're put into Medicaid. And then what kind of coverage do they have in Medicaid? Let me take a poll of the audience here. Can you raise your hand if you've ever heard of the name Diamante Driver? 1, 2, 3, 4, 5, 6, 7, maybe 8 hands. Diamante Driver was a 12-year-old boy who lived not far from where I live in Virginia. He was in Prince George's County, Maryland. And though he was eligible for Medicaid, his mother was unable to find a dentist who would accept their Medicaid coverage. They had a nonprofit that made dozens of calls to dentists, trying to find a dentist that would take Diamante and his brother. Diamante needed to see a dentist because he had a toothache. It turned out it was an abscess. It became infected, and that infection spread to Diamante's brain. By the time he was admitted to an emergency room and received $250,000 worth of surgeries, it was too late. He had succumbed to that infection. He died at age 12 for want of a dentist. I tell you Diamante's story because the government is much better at issuing guarantees of access to care than it is on delivering on those guarantees.
Well, the only thing I would say, there's no question that Diamante's death is a tragedy. I think without Medicaid, Diamante, unfortunately, would have also died with an abscessed tooth that he couldn't get served, because I don't know any dentists who take uninsured people at all.
I think that there are plenty of dentists who provide dental care to the uninsured. In fact, Missouri just passed a law that made it easier for out-of-state dentists to come into Missouri and give away free medical care and dental care to the poor, because under Missouri law,
or so there's
once a year.
I think that this conversation will continue. We're going to add someone to the panel up here right now, and that's Daniel Landon, who is the Senior Vice President of Government Relations for the Missouri Hospital Association. Affordable Care Act, the lack of expansion of Medicaid, what impact, if any, has it had on hospitals, particularly hospitals in rural areas?
It has had a significant impact.
It's created a situation where the ACA has a component related to expansion that reduces significantly payments to hospitals under the Medicare program. Takes that away. That money would be used to provide subsidies to expand coverage for people both in exchanges, but also in Medicaid. And as state legislatures and governors were given the authority to decide whether or not that would happen in the individual states, such as in Kansas and Missouri, where it's not happening, it causes those payments to be lost to Missouri hospitals. They're not coming back to Missouri, and it creates a financially difficult situation, because we still see the same number of people or more coming through our doors, sometimes emergency room doors, sometimes not, who are charity care patients. There's no one to pay their care. But it's created a financial pressure on the hospitals that I think has been significant. I would also note that our hospitals, which are bordering the 8 states that border Missouri, 4 of which have expanded. If you're in Memphis, Missouri, Scotland County Memorial Hospital, way up in the Iowa border, you could probably throw a rock into Iowa. Well, they talk to their counterparts, and they see that in Iowa, they do have a situation where the hospitals, as they say, have some more breathing room. No one is getting a windfall out of this. It was never designed to provide a windfall, but they have a level of lessened financial pressure that they don't, just by virtue of the fact that you cross that invisible line that defines Missouri from another state.
I don't know if Missouri has had this situation, but in Kansas, a hospital just closed in Independence, Kansas. And at least the CEO of that hospital said there were a number of financial pressures, as there are in a lot of small towns, but he particularly identified the failure of the Kansas legislature to push forward the Medicaid expansion as one of the significant cost issues that they just couldn't make balance anymore.
We return you to the conversation at UMKC in just a moment, but first, did the main city hospital in Independence, Kansas really just close because of the refusal of the state to expand Medicaid? The Kansas City Star asked administrators point blank.
It's a sad day for our community, a sad time for our coworkers and our patients, having come to this conclusion that closure was necessary for a variety of reasons in the community. We had the perfect storm of issues facing our hospital, everything from outmigration of our patients to other communities, declining population here in Independence, an aging facility, lack of Medicaid expansion. A variety of issues have come together along with physician turnover and the general decline in volumes that have led us to this decision.
So there are many reasons why some hospitals are now closing. That doesn't make the outcome any better for those left behind in the communities who have fears about the future.
I have a medical condition that probably would end up in a stroke. Would be the end of it, maybe. And I'm told that if you have a stroke, that they got to get you to the doctor within 20 minutes to get the right medication for it. I'm not sure they can do that here now.
Doctors won't want to come here if we don't have a hospital. So that is my concern. What will happen to the city in the future?
Hopefully you haven't had that experience yet in Missouri. But
we have, actually. In Missouri, in recent year or two, we've had 2 hospitals close. Again, it's never entirely responsible.
Sure.
Medicaid is not the sole cause, but it is certainly an exacerbating factor.
I want to be a little bit controversial here and say that if we're focused on the impact that these policy changes have on hospitals, then our concerns are misplaced. What we should be looking at is we shouldn't be looking at Medicaid as a jobs program that's supposed to keep hospitals in business and keep people employed there. The point of Medicaid is to provide health care to the poor, to improve the health of the poor. And that should be the metric by which we measure this program and all policy changes related to it. And the problem is that there is not evidence to show that Medicaid actually helps the people it's intended to help on balance. Of course, there's some evidence of benefit, but the most reliable research that has been done on this shows that it found no discernible effect of Medicaid on the physical health of the people, the most vulnerable people targeted by the ACA's Medicaid expansion.
What does it mean to close a hospital? The National Rural Health Association says 50 rural hospitals have closed in the past 5 years, and the pace is increasing. One of those hospitals, Sac Osage Hospital in Osceola, Missouri, about an hour and a half south of downtown Kansas City. Generations of Kansas Cityans have attended the H. Roe Bartle Scout Camp here, and those heading down to Branson could not have escaped its big roadside tourist attraction, the Osceola Cheese Shop. But now, after 45 years, its only hospital has been shut down, and its patients told to go to another facility 35 miles away.
When we made the decision to close the hospital, I had no idea at that point in time how complex it was going to be. It's easier to open a hospital than it is to close it. One of our biggest challenges has been the hospital converted to an electronic medical record 6 or 7 years ago, maybe 8 years ago. But prior to that, everything was paper record. These are all health protected information records that have to be shredded. They can't be thrown away. And most of these are charts that have been scanned. So this is a patient chart. And this is what they looked like before we had a computer. Pages and pages and pages of nurses' notes. When you close a hospital, you have to be responsible for every patient who ever was served there being able to have access to that paper record, or you have to digitize it and have access. So poor Connie out there at the desk, that's all she does. She sits there all day long and scans.
Up until Monday, we had 5 of us scanning, and we've been scanning every day as fast as we can scan since September. And it's took us all this time to get what we, and like I say, we're still finding some stuff now that have to be done.
We have shredded, I think, somewhere in the neighborhood of probably 400 or 500 bankers' boxes full of records that have been now digitized. So we're trying to sell off anything that is usable, that people can take and they can use it for some other purpose. And I've been hugely surprised by cabinets and shelving and all kinds of casework that people are willing to buy and take off and repurpose. Every garage in Osceola now has, I think, one of my cabinets in it. It's good.
I've been here 34 years. My daughter was born here. She's 34 now. Yeah, she's 34. Very sad. Loss for the community. We employed 1/10 of the population, and we've lost that.
But I don't think it was salvageable. The payer mix was terrible. It was Medicare, Medicaid, and self-pay, and we had 15% commercial insurance. And you just can't survive in that kind of an environment. So every month we ran at a deficit. A good month we only lost $20,000. Some months we lost $100,000 or $200,000, just depending.
Well, for years we've been struggling, to stay open, just because, it was just, every year it got a little harder. It's probably been, 7, 8 years that we've had a raise because, if we thought that would help,
Somebody told us that we would never close because a hospital never closes. So we had that in our hearts that something might happen, but.
They just started cutting people a little at a time. And, but like Carolyn, they kept saying, you can't close a hospital, but we found out that's not true.
I think the hardest thing has been the emotional impact on the staff who worked here for 30 and 40 years.
The most wonderful place there ever could be to work, and the people you work with. And it's hard to say goodbye.
Our patients were families. Everybody, most of the patients we had here was family, or neighbors, or we got to know them as family.
In a great big hospital, you're just another patient. Here, you're special. You're part of the family. And so I think that is something that the hospital provided that you don't see in a lot of places.
Let's get our fourth panelist up here, okay, and to join the conversation. And I would like for Taryn Bragdon to join us up on the stage. Taryn is the President and Chief Executive Officer of the Foundation for Government Accountability, which he founded in 2011. In just 4 years, the Foundation for Government Accountability has grown to one of the top 5 biggest state-based think tanks in the country. What is your biggest objection to the expansion of Medicaid?
I think it's important to go back to 2010 and just look broadly first at what the promises of Obamacare were. One of the first key promises of Obamacare was that the average family would see a $2,500 reduction in their premium. The next big promise, the Congressional Budget Office said by last year, the number of uninsured would be reduced by 18 million. And the last big promise was that if you like your plan, if you like your doctor, you could keep them. Well, the reality with the law is that those promises have either been completely broken or missed by a long shot. And what the law instead tried to do was to take a healthcare program that was targeted to the truly needy and expand it to a group of individuals who never received any type of welfare benefit at all. And it paid for that by enacting $716 billion worth of Medicare cuts. So just understand this for a minute. What the law did was it broke the Medicare promise to the disabled and the elderly, your grandmother, to give a Medicaid card to the 28-year-old living in grandma's basement.
Kathleen, you want to jump in here?
Well, I don't know where to jump exactly. But, first of all, the law, unlike the drug plan that was passed in the prior administration, is fully paid for. There may be disagreements about how it's paid for, but the Congressional Budget Office continues to say that having the Affordable Care Act in place not only is paid for, but actually reduces the deficit. If the promises of repeal were to go forward, the deficit would go up. That has been demonstrated over and over again. I would say that the $2,500 premium issue that continues to be debated is a look at what healthcare would cost that average family if they were paying on the old trajectory. There is no question at all, again, hopefully we can agree that this is a fact, health care costs have risen at the lowest rate in this country in 50 years. Medicare costs, Medicaid costs, private insurance costs, overall healthcare costs are rising for the first time at the rate of inflation, not double inflation, where we were prior to the ACA, and it has been year in and year out. No one has ever seen a trajectory like this, and it continues to this day. So there are currently about 22 million Americans, some in expanded Medicaid states and some in the marketplace, who have coverage today that did not have coverage prior to 2010. So the drop in uninsured is documented. It's been the biggest drop in the uninsured population ever in this country, the lowest healthcare inflation costs ever in this country, and people have coverage. But in states that have not chosen expansion, including Kansas and Missouri, there is a huge gap for the low-income individuals because that continuum of care isn't there.
We have a lot of questions coming in, Alan. This is not the Nick Haynes show. These are questions that we're getting right here, and we're like Radio Shack tonight. They've got questions, we've got answers. We're going to start with Dan Cass, who is with us. Dan, thank you very much. Your question for our think tank of experts tonight.
Thank you. Other than eliminating Medicaid or simply cutting what Medicaid pays healthcare providers, what are policymakers looking at to reduce Medicaid spending?
The best way to contain Medicaid spending is not to expand the program. And then the dominant idea among Republicans and free market advocates, which is the groups don't necessarily overlap, is that Congress, instead of giving states, instead of a matching grant where the more money a state spends on Medicaid, the more money they get from the federal government, they should give states a fixed amount and let them decide how to spend, how to use that money best to provide health care for the truly needy. Because when we're helping the poor, we're facing what economists call the Samaritan's dilemma. You want to help the poor. You don't want to let people go without medical care. Nobody wants to live in that kind of a society. But if you make such a generous guarantee of access to care to everybody, then a lot of people won't take steps to provide for themselves. They won't get out and get jobs so that they can pay for their own health insurance. And that happens in Medicaid a lot. There are a lot of people enrolled in the Medicaid program who don't need to be there. And we can talk about how that is. People who could obtain health insurance on their own. But states would be able to strike that balance between helping too little and helping too much in different ways, and we'd learn from each other's successes and failures. But what we have right now is a one-size-fits-all attempt to try to help the poor that ends up spending a lot of money for unknown benefit and encourages a lot of people to become dependent on taxpayers who don't need to be.
Well, I would agree with Alan that states should take the lead, and the good news is they have. With the expansion of Medicaid in 2010, states began looking at very innovative approaches to really look at delivery system reform. I think 20 years ago, Medicaid could have been accused of a one-size-fits-all with very mandatory benefits and programs. It now has lots of variations across the country that are being tested and looked at as the best way to deliver care. Iowa has a Healthy Iowans program that is very much fundamental to that case. Many states have now designed Medicaid programs to look exactly like the benefit package that someone would qualify for in the private market to make it much more seamless for families to move in and out.
Yes, I just think the facts speak very differently to that. The whole approach of this law and this administration when it comes to the states is our way or no way. You look at states wanted to have a work requirement to actually pull people out of poverty rather than give them a Medicaid card while they are trapped in poverty. Denied. You have the case of nuns who asked for a health benefit that wasn't offensive to their religious beliefs. Completely denied. You have the case of state after state. Iowa, a great example. Iowa asked to reduce ER usage if we could go from a $5 copay to an $8 copay. Denied.
Iowa has expanded their Medicaid program. We approved the governor's plan.
You did?
We
you
did.
repeatedly
We did.
denied
Iowa
key
had-
aspects of the governor's plan?
We negotiated with
okay.
Iowa, but Iowa is correct. Iowa has expanded Medicaid. Republican governor expanded Medicaid in Iowa.
I wanted to focus on the aspect of the question relating to cost. Let me point out two things. Well, first, I think we all agree entirely that it is a good thing that states be the laboratories of democracy. Again, I worked for the state legislature for a long time. It's important to have 50 state legislatures out there doing different things and looking for waivers for different ways, because not everybody is going to approach this the same way. But on cost, I'd mention two things. It troubles me a bit when people talk about Medicaid cost, because Medicaid is a pretty varied program. In Missouri, 28% of the enrollees are aged, blind, or disabled. They generate 64% of the cost. The second thing I'd mention about cost, in Missouri, of the Medicaid hospital costs that were generated, I believe, in 2012, 5% of the enrollees generated 52.3% of the cost. You might say, that's terrible. They're abusing the system. Well, our data people looked at it and said, well, let's look at people who aren't on Medicaid. 5% of the enrollees generated 50.3% of the cost, essentially the same. We've tried to emphasize that if you want to do something about cost, you find those people and you manage them.
Okay, Nick, your next question.
This is also an experiment in democracy right here. And we have lots of questions coming in, including one from the C. Everett Koop of Kansas City, our public health director, Rex Archer. Would you mind standing for us, Dr. Archer?
So you're proposing to eliminate a law before passing something that's better. And I guess that's my concern is, you know, other countries through single payer or other systems have solved a lot of these problems at lower cost and have given access to everybody. They haven't driven people to stop working. And so I guess the question is, why repeal something until you actually propose something that's better?
Okay, thank you. Even as Congress was debating the ACA, but Congress ignored it, are innovations that move in the direction that I was talking about, guaranteed renewability. In 2008, United Healthcare rolled out a product called Continuity. Has anyone here heard of it? Do not raise your hand if you're an insurance agent. No one here has heard of it. This is a product that United said, look, you want health insurance? Come to us. We'll quote you a premium, and if you don't want to buy the policy right then, we'll sell you the option to buy that policy anytime you want, no matter how sick you get. You only have to pay 20% of the premium each month. That is effectively health insurance for 20% of the cost. It does almost everything that the ACA tries to do with its extremely elaborate and oppressive system of price controls and mandates and subsidies. It allows people to buy health insurance at standard rates no matter how sick they get. That was being rolled out right as Congress was debating this law. They totally ignored it. They passed this law and it destroyed that innovation and further innovations that we would be seeing. That's the kind of healthcare sector that I want to see, and it will start to grow organically if we get rid of this law.
Definitely.
I served as an insurance commissioner for 8 years and spent an inordinate amount of those 8 years fighting with insurance companies to try and get people the benefits they had paid for. And I saw over and over again people who were just denied coverage or medically underwritten, which means an insurance company said, yeah, you have a knee problem or a heart attack or you're a cancer survivor, and we're just not going to insure that. Anybody who worked for a large employer didn't have that problem. You worked in the employer, you got in the employer coverage. But if you were buying insurance on your own, you were in the Wild West until the Affordable Care Act. And the portion of the marketplace that it changed was for people buying their own coverage. And it said, never again can insurance companies deny you coverage based on your pre-existing medical condition. You can't be kicked out if you get sick. That was a brand new law, and it was federalized, and it was way overdue. because there were way too many folks who were fine until they got sick, until their family member got sick, until somebody had a child who had special needs and they needed to renew that policy because they could be locked out or priced out or dumped out of the marketplace.
Ms. Sebelius brings up a point that was a problem in the market in certain states. But the solution to that problem was to blow up the entire system and have everybody who had a plan that they liked, that had lower premiums, they had to get rid of their plan. So I live in one of the top 20 fastest growing parts of the country, in Naples, Florida. Next year, I'm on my 3rd canceled plan for my family. Next year, we have one carrier in one of the fastest growing communities in the country. That's not more choice, that's complete lack of choice, and that one carrier has, the premiums are twice what we were paying before.
Nick, there you are.
I'm right over here.
Okay.
And actually came from a National Health Service country. I'm actually 85 years old. I'm not saying that that's a good service. We have a question next from Ron Fugate in Overland Park. Can you stand for us, Ron? Your question, please.
Right. My son is 41 years old. He's developmentally disabled. He has worked for 22 years at a major hotel. And just recently, within the last year, management decided that he's not fast enough and that his hours have been cut in half. He will lose his job at the end of November. Along with that, he will lose his health benefits. Thankfully, he will have the Affordable Care Act that will provide health coverage for him in the absence of the coverage that he loses through his employer. On the other flip side of that, he will have to go in to a community-supported organization for people with developmental disabilities. And in the state of Kansas, there are now over 5,000 people with disabilities awaiting to get Medicaid funding to support those services. What do you say to my son, who is under these circumstances really between a rock and a hard place?
I think I would say the same thing I would say to my 48-year-old cousin who lives in Wayne, New Jersey, works at a grocery store there, and is in a similar situation where if he loses his job there, he could lose his health coverage. First problem there is that 90% of people with private insurance in this country have insurance through their employer. Insurance that has the peculiar characteristic that when you get sick and can't work anymore, in other words, when you need it most, it disappears. So the first thing we have to recognize about your son's situation, my cousin's situation, is that they have been made more vulnerable by the government's effort to tinker with the marketplace.
Why?
Because what created, I know what you're thinking. Wait, this is employer-sponsored insurance. But the reason that 90% of Americans with private insurance have it through an employer is because the government provides a huge tax preference for employer-sponsored insurance. What I would like to see is repeal of the ACA so that more people can afford health insurance without needing subsidies just because they're being exposed to hidden taxes. There would be some program to provide coverage for people who have high-cost conditions, can't afford it on the marketplace anymore. States would get a fixed amount of money from the federal government so they could do a better job of trying to figure out, all right, who really needs the assistance and who doesn't. Because I'll tell you something, I don't think my cousin needs the assistance. I come from a big Irish Catholic family. He has a lot of people on whom he can rely, his siblings as well as cousins. So if we create an entitlement program that sweeps him up in it, he probably doesn't need to be there.
Well, I would say that Michael's cousin is in a different situation because New Jersey has expanded Medicaid. Their Republican governor chose to move ahead. So your cousin has a range of options. In the situation that was just described, with a person losing a job, he or she now has an option for coverage outside of their employer, where before 2010 they really didn't, unless you could come up with 100% of the costs of your old coverage, called COBRA. you really were out of luck. And COBRA ended after 18 months, so after 18 months, you were really out of luck. I'm very troubled that in Kansas particularly, the waiting lists for the developmentally disabled have grown exponentially. But that's a choice, unfortunately, that the governor and the legislature make about budget allocations. It isn't that they somehow don't expand Medicaid because that's going to make the waiting list go away. They have chosen consistently not to expand Medicaid, which would actually bring additional resources into the state.
Okay, Nick, I want to get to you. Do we have anything from our fact checkers?
We do. We have some short, pithy questions and a fact check. You asked earlier, what was the number of people that were on the Affordable Care Act, or uninsured rather, before the Affordable Care Act went into effect? And what about afterwards? Stephen Larson has been coordinating these facts for us over here with our friends at the UMKC Library, and what was the results of that?
The results were, Nick, that in Q1 of 2008 in the United States, that 14.6% of uninsured Americans were living. In 2013, that rate rose to 18%. But in Q1 of 2015, that rate dropped to 11.4%. And keep in mind that the population of the United States increased greatly in that 7-year period. The source is Gallup.
Our fact check is working for you. We have a pithy question here from Jane. Why are states allowing for-profit publicly traded insurance companies take over Medicaid, making sure even less goes to the poor?
Who would like to start with that one?
You have a dynamic where in a lot of states, under old Medicaid, that there was a one-size-fits-none. So a lot of states have moved into the direction of, we want to have more competing private plans. A lot of states that do this still have a default that if people want to stay in old Medicaid, that they can stay in old Medicaid. With the idea being that if people have several different private choices, and the individuals then have a way to go and vote with their feet and go to another plan if they're not getting the services that they allow. I think that kind of choice is much better in Medicaid. Frankly, you heard my own story. I wish I had those kind of options in the county that I live in Florida. But instead, because of this law, my choices have been limited. I now have one carrier, and the plans that are available to me are twice as much as they used to be and have much higher deductibles. So while Ms. Sebelius can talk about the fact that health premiums have been flattening, so have incomes, and deductibles have been skyrocketing.
Nick.
There's a lot of economics questions, of course, and we're answering those. But the most burning question of all, do you know what that is, of this whole pack? And it's coming from Lisa and Miriam, Brad in Kansas City, and Don in Leavenworth. It is killing me. What is Kathleen Sebelius doing since she left the Obama administration? And would she run for political office again in Kansas?
No.
What are you doing now?
I would say I'm doing a portfolio of activities. I'm working directly with some companies in the healthcare space. Many of them are startups and have exciting ideas about better care or interesting, innovative biomedical products. I'm working on a health project with the Aspen Institute. I am doing some speaking and some financial consulting and saying no to lots of things that I don't want to do, which is great.
Okay, look, I want to roll something by the panel here.
Hanging out with my grandson also, 3-year-old, very smart, wonderful.
And that is because we've talked a lot about what the Affordable Care Act did and didn't do. One thing we know it did, and I think that some people have dealt with it here a little more glibly than others, which is the elimination of the pre-existing condition. The question is, if you have a heart disease, if you have diabetes, if you had tuberculosis, if you have any large or small number of things, going into the marketplace and getting insurance, if you could, was astronomically expensive and might be dropped after the next treatment. That no longer is the case, is my understanding of the law. Is that, and if you repeal the law, how do you sort of get it back?
Well, I would dispute the premise that this law has eliminated discrimination against people with pre-existing conditions. And I want to tell you the story of 2 people, Ian Pearl and Shelby Rogers. Ian Pearl is a guy about my age, born not far from where I was born, in Jackson Heights, in Queens. He's got, I think, muscular dystrophy. He's confined to a wheelchair, he's on a respirator, and his health plan dropped their plan the plan that his father's business had, and reissued a new plan that dropped the 24-hour nursing coverage benefit. Shelby Rogers happened to grow up close to where I grew up in McLean, Virginia. She has spinal muscular atrophy. She's also confined to a wheelchair. She needed help from a nurse to turn her over in bed at night lest she get pressure sores. She was covered by an Aetna plan through the Federal Employees Health Benefits Program. And her insurance company, Aetna, actually following the lead of other insurance companies, did the same thing, dropped that very expensive 24-hour nursing care benefit. Now, why did they do this? Is it because insurance companies are evil? Is it because they're greedy? Is it because it's because they were responding to the incentives in which of the market in which they were operating? All they do is tell the insurance companies, you can't vary the premiums that you charge people based on their health status, but the discrimination comes out in other ways.
I don't know if Michael wants more regulation, so insurance companies would have to have a mandatory set of benefits that they would have to provide. That was not part of the law. But there is no question that underlying that is a law that says no longer, never, ever again can an insurance company lock somebody out, dump somebody out, or limit coverage based on a pre-existing health condition. That is part of the law that was never there before. It is in place now. Now, I can't speak to what in New York has had community rating for years. It had nothing to do with the ACA. It well preceded that. The Federal Employee Benefit Plan has a large group policy, some of which cover some benefits and some don't. There are choices that all federal employees have about what benefit suits your family. Both of those are not related to the ACA, but there is no question that for the first time ever in the United States, there is a law that says insurance companies cannot any longer discriminate against people with pre-existing conditions. They can buy insurance coverage, and that has never been part of the law.
Still to come on this special hour-long edition of the program, more of your healthcare questions as we return to UMKC's Pearson Auditorium. But first, year 3 of open enrollment for Obamacare has just begun. What makes this year different? Here are 5 things you need to know. Number 1, you have until January 31st to sign up. The penalty for not getting health insurance is doubling. How about almost $700? Kansas and Missouri residents are seeing a big double-digit increase in premiums. More than a 20% increase on the most popular plan in Kansas City. Experts claim that's because some insurers, like Coventry, are dropping out of the marketplace entirely. But health officials insist 7 in 10 enrollees will still pay premiums of less than $100 a month. If you still have anxieties about the healthcare.gov website, it's working better, and officials say a maddening glitch that resulted in customers getting locked out of their accounts has been fixed. And the mandate is kicking in for the first time for smaller employers with more than 50 workers. Watch for that, because if your boss now offers you insurance, you're no longer eligible for a subsidy if you currently are enrolled in a marketplace plan. Small business owners with more than 50 employees can't just blow off providing insurance either. The penalty for not providing health care is $250 for every worker.
Well, I want to get a question from Nick. We'll get back to that in a second. Nick, go ahead. What's next?
One of the things that characterizes this kind of event versus others is that we have fact checkers, Alan. And they've been getting lots and lots of fact checks coming in. Okay. And sometimes they can be sort of nitpicking on little details that are, is it worth interrupting the conversation for? But a lot of things have been said about an Oregon health study, and after Medicaid expansion there, was there really any difference in the healthcare outcomes? And it was stated on the panel that there wasn't any difference in the healthcare outcomes. But we're going to go back to our fact checkers who have been looking into that. Stephen Lawson, what did you find? Would you mind standing up for us?
Sure can, Nick. So we actually found 3 very interesting differences between those who had Medicaid and those who were non-insured. Those who did have Medicaid found that they had increased use of healthcare services overall. It also raised their rates of diabetes detection and management, and lowered rates of depressions in the enrollees by 30%.
Nick, you have one more.
Mike in Kansas City, Missouri has a question for our panel. Mike, your question, please.
Speaking as a refugee from the insurance industry for 25 years, I want to thank Mr. Cannon for describing the evils of insurance companies. That seems to make a great case for the free market, but there is no free market in healthcare, so single payer is the only option. Is that correct?
I think that insurance companies are like other human institutions. They respond to the incentives with which they are presented. And the government in the ACA creates incentives for insurance companies. Oh, and even employer-sponsored insurance, where most of you probably got insurance, either have insurance or got it through your working lives, creates incentives for insurance companies to cater to the healthy and mistreat the sick. So you're right, we've never had a free market in health insurance in this country. And so we've never seen what sort of innovations, we've seen some innovations, but we've never seen the full range of innovations that the market would develop to solve that very thorny problem of how do you get people to keep their promises to the sick?
I would just jump in for one moment to just say, I don't think it's rocket science, and I don't think it's necessarily evil. It doesn't take much to figure out if you write health insurance, it's better to have people who don't get sick. It makes sense to have people promise they won't get sick and use their insurance. That is a pretty good strategy, or that your house won't burn down, or that you won't have a car wreck. I mean, it's the same thing. So until you, I would say, equalize that and say people can't screen for only the healthy patients, you can't deny people coverage, then you will have that continued incentive operate in the private marketplace. And that's one of the, I think, big steps forward that we're seeing. I don't know if Michael's advocating for a single payer, but that would take a level of administrative costs absolutely out of the system and make us look more like every other country on earth.
Not everybody likes to ask their own question. They tick a box and say, have Nick ask the question, like Frank, and I have to decipher the handwriting. With all the problems in healthcare for profit resulted in hospitals closing down and requirements leading the needy without coverage, wouldn't it be better to place all general health care in the not-for-profit sector?
There's this notion that for-profit is bad and not-for-profit is good, when really it's a tax distinction. You still have to have income higher than expenses, whether you run a not-for-profit or whether you run a for-profit. And I think that there's this notion that somehow those that run not-for-profits are more benevolent and less focused on the bottom line. I used to live in Maine. We have 39 hospitals that are all not-for-profit. I can tell you that some of the best care that we've received is at hospitals that are not-for-profit and also at hospitals that are for-profit. They all have the same financial incentives. And I think to project that one group wears a black hat and one group wears a white hat is just not true.
Well, I would just suggest that as you look at the economics of health plans, Medicare, with about 53 million beneficiaries, has the lowest administrative costs, runs at about 2 to 3%. A lot of private insurance companies are in the 15 to 20%. Medicaid also runs at a very low administrative cost, which is just by way of saying that most of the costs of those programs actually are delivering services. Now, do hospitals make money off those services? We hope so, because they'll keep their doors open. Do doctors make an income off the services they provide? Yes. Is it too much or too little? That, I think, is an ongoing debate, but most of this money is going into the private marketplace, healthcare providers, doctors, nurses, dentists, drug companies, device companies, and it is not government-run anything. It's government paying for benefits that are delivered by private sector employees. We have a little bit of misnomer about who actually is paying for and who delivers the most efficient care. And I don't think there's any question the government programs, year in and year out, deliver the most efficient levels of care, less administrative costs, less overhead costs than do the private sector programs.
Nick, last question.
One of the laws of the American public square is that the questions come completely from the opposite side of where I'm actually standing. And I now go to Beverly right up front here with the next question. Would you mind standing for us, Beverly?
Not at all. I'm a health insurance agent and the past president of the Greater Kansas City Association of Health Underwriters. And Mrs. Sebelius, I'm disappointed to hear you continue the myth that prior to Obamacare, ACA, that in the individual marketplace, they could drop you from coverage just because you got sick. We have guaranteed renewability and have for years, and they could not do that. That was against the law before.
Well, I beg to differ. We actually sued some insurance companies for rescinding plans. They were running algorithms on people with HIV/AIDS. They were doing a variety of things. It was also what a lot of companies did was lock people into a plan. So they'd let everybody else out. They'd lock an individual in, and the rates would raise 15, 20, 25% a year. So you weren't necessarily, in that instance, dropped from the plan, but you couldn't get into any other plan, and all the healthy people could get out of the plan.
So then we passed the law in Kansas that stopped that algorithm type thing from happening.
In Kansas.
Okay.
Nationally, it was not the law.
We're going to close now, and I want to first of all, I want to thank each one of you for participating in the panel tonight. I like to think that we can demonstrate how people could significantly disagree without being significantly disagreeable. But one of our customs is we present each panelist with their own engraved civility bell. The idea is we want you all to put it in your office, and when things get a little loud or someone gets a little uncivil, you now have a way to shut it down.
I could have used this at a few congressional hearings.
This special healthcare edition of Kansas City Week in Review is made possible by the generous financial support of the Healthcare Foundation of Greater Kansas City, working to make Kansas City a healthier place by helping the uninsured and underserved get the care, support, and education they need. Additional support has been provided by
Reach Healthcare Foundation, a philanthropy dedicated to achieving health equity for all people in the Kansas City region by removing barriers to healthcare coverage and expanding quality healthcare. Information is available at reachhealth.org.